It is asked to me to speak about the aging patients, and so I will try to describe who are aging patients. And I think it's very important to understand, if we wanted to optimize a treatment, which are the outcomes that we ask for this treatment. I will try to give you an epidemiological perspective of what are the drugs that geriatric patients currently take in the HIV setting, and I will try to give you some perspective regarding the use of antiretroviral therapy in the context of polypharmacy. And so, as you know, I'm a clinician, and so I think the best way to start is to show you a picture of a patient. Actually, I visit this week. His name is John. He's 62 years old, and so actually, he's not a geriatric patient. Geriatricians like to see patients above the age of 65, and so I cannot say he's a geriatric patient. He's professor at university. Actually, I follow many professors of university with HIV. That was why I was quite skeptical when they asked me to have an academic position, because I don't know if it is a risk factor for that. Nevertheless, actually, this guy is well, let's say not overweight. His BMI is 22. He never smoked one single cigarette in his life. And he's got some mobility impairment. I will show you why. With regard of his HIV history, you see that actually he's been living with HIV for 22 years. He was not an AIDS presenter, but he's got a very low CD4 nadir, and maybe this is the reason why he had not fully restored from his immunological point of view, and he's far from having a CD4-CD8 ratio above 1 or above 0.8, which is something that more and more we believe it's important to gain. And actually, you see that there are some markers of immune activation if we want to enlarge our immunological profile, also adding CD8, CD38 phenotype. With regard of antiretroviral therapy, I was thinking, well, he's got a long list of drugs he took in his life, after I will show you, and I tried to say, how can I summarize? Well, for sure, he's been exposed for 2 years in the pre-HAART era. For sure, he has been exposed to first-generation HAART era, and so lots of D4T, lots of unboosted PI. He had 5 years of let me say, standard PI-boosted PI, and more recently, for the past 5 years, he had unconventional monotherapy with darunavir, boosted darunavir. It's 1 year he's undergoing Genvoya treatment, and I will go through this in next slides. Actually, I visit him, and anytime I visit, there's many things to discuss because of his previous medical history that still need to be cared. Well, first of all, he had the recurrent fascial plasia. Actually, this was even before HIV infection, and so person may come with some diseases that are even before HIV infection. Actually, in the year 2000, he had dyslipidemia. Now, he's got high doses of statin, and actually, we are able to obtain very good level of LDL, and so I'm pretty satisfied about that. In 2001, he developed lipodystrophy. Now we know that lipodystrophy is not one disease, it's at least 2 different diseases. And so he's got lipoatrophy. And you see in these years, from 2001 to now, we've got leg fat percent with DEXA. And to what extent he was able to recover. And so he's gaining fat in his leg, regardless of the fact that if you look, there's still quite sign of peripheral fat loss. But you see the leg fat percent moved from 9 to 70%. But actually, what is more relevant is the fact that in the same period, lipohypertrophy was worsened. And so in my experience, lipoatrophy is a fading away condition. Lipohypertrophy is an epidemic condition, even in the, let us say, current antiretroviral era. A very important issue is that he developed not a bone disease, let me say a vascular disease, which is bilateral osteonecrosis of femur heads, and he had in 2003, bilateral hip replacement. Actually, this is the reason why he still has some mobility impairment, and he's got very difficult to make him exercise. More than that, in 2009, he developed diabetes mellitus, and maybe in association with that, in 2014, he developed myocardial infarction, regardless of the fact that he was on primary prevention from myocardial infarction, and he had even one recurrence after that. Last but not least, now what we are worried about is that he's developing sarcopenia. You see that in the past years, the ratio of lean mass of the limbs compared to the trunk has decreased, and he's got weak hand grip, less than 24 kilo, which is really below the 10 percentile of the population. And now he's got hypergonadotropic hypogonadism that for sure doesn't help for his sarcopenia. And so you see, actually, the issue is that HIV is one of the many diseases I'm taking care of this guy. And actually, if I have to describe this guy, is it a comorbidity? No, definitely it's multimorbidity, and there's many diseases in which one is associated to the other, okay, and I need to treat them contemporary. Do you ask me what are the most relevant diseases in this guy? I really don't know, because actually it's not one disease that is more important than another. Well, I may say he may die from an acute myocardial infarction shortly, but actually, once again, it's not one disease. It's multimorbidity that describes the complexity. Well, is it multimorbidity that describes the complexity? Well, I came over this paper that to me was very important. I believe that, as in general population, also in HIV, we are experiencing the end of the disease era. This patient has not a disease. This patient has got multimorbidity, but actually even more, actually the relationship between multimorbidity describe frailty in this individual. And I believe that this is true for other disciplines outside geriatrics, and so imagine cardiogeriatrics, imagine oncogeriatric, but this is true also for HIV. I will not make you get annoyed about frailty. I always speak about frailty. I show the definition. I just give you this picture just to remind you there's a different approach about frailty. We must not miss the fact that frailty is, let me say, a condition that must not be identified to the tool that we use to measure frailty. This is very, very important. The tools that we use is frailty phenotype, just looking the difference between images, but also another tool is the frailty index that count how many difference there may be between a fit and a non-fit individual. And so let me go back to John. Is he frail? And so actually we look at his frailty phenotype. John moves slowly. He's got weak hand grip and he feels exhausted. Definitely he's got phenotypic frailty. But also look at all the frailty index points that we were able to build up. Actually, I do not do nothing. It's an engineering that look in my database, and every time I put a visit, it pops me up the frailty index in my electronic chart, and you see that in several years that he reached the cutoff of 0.28, which is the cutoff of frailty in my clinic. But also look, this is interesting, the fact that frailty, either measure with frailty phenotype or frailty index, found its, let me say, anatomical correspondence with regard of sarcopenia, okay? And so in 2008, this guy had 62 kilo of lean mass. Now he's got 51 kilo of lean mass. And actually every year he's losing half a kilo, 1 kilo, 2 kilo of lean mass. And for us, this is something very important in a patient who is not yet in the geriatric area. Okay, but also we need to measure to what extent sarcopenia relates with physical function. We do a test which is called short performance physical battery, 4 point out of 15, and so very severe impairment. Definitely because of the fact that you see here, there's the scar of the 2 hip replacement. And so definitely there's a mobility situation that impairs so much this guy. Okay, I told you, do not miss the frailty conceptualization with the measure of frailty. This is a recent study that we published in which actually we compared in the same casuistics, frailty index and frailty phenotype. This is just to tell you, please do not think that at the clinical point of view, the pre-frailty condition using the frailty phenotype classification worth for nothing. It's worth just for writing papers. But actually telling I'm a pre-frail from a phenotypic point of view has no relation at all with regard of frailty index, but also has no relation at all with really clinical adverse outcome. Now, let me say something which I believe is very important. And so I spoke about John and say, well, this is a complex patient. Is he complex because he's got multimorbidity? Is he complex because he's frail? And so actually, there's an ongoing debate also in geriatric medicine to say, are frailty and multimorbidity different way to think about the complexity of the patients? But actually, the point that we need to understand is that multimorbidity is dependent on the diagnostic capacity that you have. And in an old person, the more you diagnose, the more you look, the more you find diseases. I told you about sarcopenia in this guy. I guess that most of the center here don't measure sarcopenia in their HIV patients. Okay? And so the point is that I need a tool that goes beyond the way that I perform my intensity of care. And so actually, I need to think that there's an evolution. On one side, the association between frailty, disability, and multimorbidity can frame a clinical condition. This is a phenotypic model. Another possibility is to think that frailty and multimorbidity can be used to predict disability. Actually, this is what I was doing in my clinical practice so far. Have you got multimorbidity? Yes. Are you also frail? Yes. I guess you will turn to be disabled. Okay. But actually, there's a different way. This is the so-called model for adapted care, in which actually frailty is the big frame in which disability and multimorbidity gets in. And so let me translate it in the situation of John. In my situation, actually, I believe that HIV, as well as other comorbidities, contribute, are part of the frailty of John. And so I would not say frailty in HIV, but rather HIV in frailty. This is not just semantic, it's a different way. I recognize, first of all, that John is frail. HIV is a part of this frailty, as well as myocardial infarction, as well as sarcopenia, as well as dyslipidemia altogether. But the point is that I need a model to say, I treat his frailty first. There are things to do if you've got a frail individual. And actually, you treat not just because you want to prevent disability. John already has got disability, okay? Yes, because of the fact that if we look, his instrumental activity of daily living, he's fine. But if you look at the CATS index, he's have got difficulties in toileting, in transferring, and so there's already some disability issue, as well as his quality of life is already impaired, 60% using AQ5D, 5L, and also there's a mild depression, and he also has some geriatric syndromes. Regardless, frailty also falls, and hearing impairment. So you see the way in which I say, who are the people in which I need to optimize antiretroviral therapy? Are they because they are old? Are they because they are geriatric patients? Or rather, because of the fact that I wanted to study HIV in frailty? Okay. Well, what to do with antiretroviral therapy? Well, this is the long story of antiretroviral therapy of John. You see, actually, the way in which I've tried to summarize all this condition. Can I give you any evidence-based guidelines? Are there any guidelines that tell me which is the best way to treat with antiretroviral in frail individuals? Actually, these are the most used guidelines, and there's no mention of frailty in any of them. Why? Well, because there's no studies. So far, there's not one single study on antiretroviral in which frailty was used either to include patients or to use frailty as a clinical outcome. And so actually some years ago I was asked to say, well, there's no study which kind of drug you would suggest anyhow. Well, and so I say, well, there may be some classes that seems to be more easy, okay, because of the fact that an older person may have multimorbidity. Multimorbidity may induce polypharmacy. Either because of multimorbidity or because of polypharmacy, I would say, well, maybe INST inhibitors are easier than PI. Okay, that's generally speaking. But again, I don't have frailty as a clinical outcome to give you suggestion about the drugs to give to patients. This is true, but in fact, old and frail individuals are already in our clinic. And so, which drugs do they take? And so this is a paper we published this year. Actually, this is a large cohort, 1,100 people above the age of 65. It's the first time in which we collect antiretroviral use in people above the age of 65 in this large group. All these patients are from northern Italian center. And the first surprising, or not surprising thing, is that more than 30% of these individuals are actually doing non-conventional antiretroviral treatment. But let me say, well, there's some 60% that are doing conventional treatment. Actually, there are 839 patients. Which drugs they are taking, which combination? Actually, 113 different combinations. Wow! But if you take non-conventional, out of 300 patients, there's 68 different antiretroviral combinations. You understand, we are not treating the same combination more than 4 patients, okay? Every 4 patients, we change the drugs. We don't have so many clinical trials. It means that actually, this is a jungle of antiretroviral prescription, okay? But what leads the fact that there's so many monodual therapy? Again, it's polypharmacy and multimorbidity that makes physicians choose dual therapy for these individuals. What leads the fact that there's lots of patients in which NRTI are not more the backbone of the treatment? It's duration of HIV infection above 20 years. What leads the fact that we want to avoid tenofovir in this individual? Again, polypharmacy and multimorbidity. And is there a reason why we want to avoid boosted regimen? Well, this is not apparent. It was very surprising for me. I would say, well, let me say the boosters may have much higher impact on polypharmacy. Actually, this was not shown in this casuistics, and so either HIV physicians do not care so much about drug-drug interaction, or the current, maybe cobicisted regimen are much less harmless than what were the ritonavir boosted one in the past. yes, I rush a bit just to say, well, we need to recognize that we don't have studies, but we need to have stress studies. And so I think this study, in which not frail individuals were used as inclusion criteria, but in fact individual with already existent chronic kidney disease was the including condition. As you can see from the baseline characteristic, the age of this individual is totally different what we see in registrational study. And I guess that inside this age group, because of the impact of chronic kidney disease as a multimorbid condition, there have been a lot of frail individuals inside. We know that actually in this situation, TAF performed extremely well, and actually there was no age difference with regard of the occurrence of adverse event that produced a discontinuation of drugs. But what was more interesting to see is that the baseline kidney condition did not change the evolution of kidney disease, or even we had an improvement in bone mineral density. This is still difficult for me to understand because of the fact that there is always an aging effect of 1% reduction in BND every year we get older. And so to me the point is that, well, maybe something is changing. Maybe there's a situation in which the TAF in this jungle of prescription is not useful just because of the fact we've got less harm because of the bone, because of the kidney, but because presumably we will return to most standardized regimen. And so I think that this jungle of prescription will be reduced because of the fact that now TAF will allow to have evidence-based treatment that is something that physicians want to use. It's not true that they don't want to use. 2 words about polypharmacy, very 2 words, okay. And this is to say, recognize that John have got 1 pill with his antiretroviral, 9 pills for the treatment of comorbidities. The point I wanted you to understand is that you need to think that there's a iatrogenic triad that we need to be afraid of. Polypharmacy, drug-drug interaction, and potentially inappropriate medication in older individuals. With regard to polypharmacy, we all recognize that the burden of polypharmacy is increasing in our patients, and actually the consequence for that is even associated with adverse event. And so what geriatricians do is to take out drugs, not to add drugs. The second issue is drug-drug interaction. We've seen this table many times, and we know there are now decision support systems that allow us to give important situation. But the new thing that is not well explored in HIV is the fact that actually there's potentially inappropriate medication use in elderly individuals. We need to look which drug should not be present, which one should be present, which one should not be used in certain disease condition. Just to give you some data that I will present in EACS meeting, actually 68% of population in our cohort, and we run a metabolic clinic in which we are very much attentive, actually have potentially inappropriate drug prescription. And so this is my last slide, just to say, I think that aging HIV patients are not necessarily old, okay? I think that optimization of antiretroviral therapy are needed in patients with multimorbidity, polypharmacy, and frailty, even when viral load is undetectable. The benefit of antiretroviral optimization consider multidimensional health domain, including quality of life and successful aging. TAF benefit goes beyond its reduced toxicity and needed to be compared with new regimen, like for instance dual INSTI regimen. And antiretroviral optimization might be considered in the context of polypharmacy, of drug-drug interaction, and potentially inappropriate medication. And active clinical intervention, including pharmacists, are urgently needed to manage antiretroviral in context of aging patients. Thank you so much.